I'm Michael Hitchborn, and you're watching the American Life League Report. The pill kills babies. Did I get your attention? Here, let me say it again. The birth control pill kills babies. Does that surprise you? Well, the medical community knew this 50 years ago, but by manipulating a few medical definitions, they hid the fact that the birth control pill and the IUD are abortifacients. Here's a video to show you how it works.
The progesterone has two effects. First, it thickens a woman's cervical mucus to impede the movement of sperm en route to the egg. Second, it dries up blood vessels along the uterine wall. So if a sperm still reaches the egg and fertilizes it, the embryo has nowhere to implant, but is lost in a woman's menses.
Up until around the mid-60s, how pregnancy begins really wasn't something worth debating. It was solid science that conception occurred at fertilization. Even the US government knew it. They recognized that anything preventing implantation caused an abortion. Back in 1963, the health department put out a leaflet that said, "All the measures which impair the viability of the zygote at any time between the instant of fertilization and the completion of labor constitute, in the strict sense, procedures for inducing abortion." Now, this kind of language posed a major marketing problem for the birth control movement. And so the only way to make these drugs acceptable to the general public was to change the definition of conception. In 1965, the American College of Obstetricians and Gynecologists, or ACOG, totally changed the words used to define pregnancy. They changed the definition of conception from the union of egg and sperm to the implantation of a fertilized ovum. They changed pregnancy to the state from conception to birth. And if abortion is the disruption of a pregnancy, then drug companies have all the language they need in order to avoid labeling the birth control pill as abortifacient. So here's the bottom line. A few people in the medical community deliberately confused the language in order to hide the fact that the pill kills babies. That way they can make the IUD and the so-called birth control pill marketable.
For ACOG's Guide to Language and Abortion, here are the terms they don't want people to say anymore. Late-term abortion, chemical abortion, surgical abortion, heartbeat bill, fetal heartbeat, dismemberment ban, abortion provider, baby or unborn child, self-induced abortion, elective abortion, partial birth abortion, womb, or abortion on demand. Those are all things ACOG would like to replace with other phrases or just remove entirely. And then in contrast, APLOG, this is most of the list because you guys did have a little bit of crossover when it came to heartbeats and things, but the list that's exclusive to APLOG, terms that they would recommend you replace are the word abortion, which we'll talk about in a second, termination of pregnancy, spontaneous abortion, non-viable embryo, threatened abortion, products of conception, medically indicated abortion or therapeutic abortion, lethal or incompatible with life, fertilized egg, abortifacient, conception, failed abortion, abortion, ban or restriction, and there's a few more after that, but those are the ones that I felt like really focused on the patient relationship right away. I was reviewing these two documents to prep for this interview, and I was noticing that, from my view, broadly speaking, ACOG seems to be wanting to use the word abortion more often with less qualifiers and also kind of with less description. So, for example, they don't want anyone to say elective abortion, just the word abortion without any explanation. And they don't want people to say surgical abortion, just abortion procedure. Just things get vaguer with theirs. And APLOG actually is almost going in the opposite direction, where the recommended phrases you have don't use the word abortion at all. You've extracted the word abortion and just started describing exactly what you mean. And from my view, it seems like APLOG is trying to get away from the confusion around the word abortion and just be very specific about what methods and what circumstances you're describing. And ACOG seems to want to not be specific at all. They don't want to ever discuss reasons. They don't want to get too specific. They don't want to be too clear with layman's terms or clear language about processes. They want to use very opaque and vague language when describing this. Do you have experiences, or do your members of APLOG have experiences with patients being confused by this? You know, when you developed this, was part of it patient clarity?
Yeah, absolutely. So first of all, I think that your observation is spot on in that we are calling for more specificity so that patients truly understand what's going on with them when we make a diagnosis or when we're treating them, and also so the general public can understand exactly what we're talking about when we talk about these policy debates. Just as one example, I have had several patients that I've treated, and I know colleagues have had a similar experience for a miscarriage. So I think everybody probably knows what we're talking about when we talk about a miscarriage, but just to clarify, a miscarriage means that the embryo or the fetal human being has passed away spontaneously, not through any intervention. And technically the medical term for that right now is spontaneous abortion. And so that's a medical diagnosis that they go home with on their paperwork. And I've had several patients that called back into the office afterwards very upset because they got home and they looked at their discharge paperwork and they saw that diagnosis on there. And there's been sort of a couple reactions that I've had when patients have called. One, somebody very upset that was even on their paperwork or in their chart anywhere, because they've said, well, I would never have an abortion, so why is that on there? Or two, someone genuinely confused and calling and saying, is that what happened? Did I have an abortion? And
this is a small divergence, but speaking of that, I recently did some content about the Society of Radiologists that came out with a lexicon where they were making recommendations to medical professionals who do ultrasound. And I fully expected them to recommend that they stay away from words like heartbeat or anything that uses the word heart. They want you to measure the beats of the cardiac organ that is not a heart. And I expected that, and it was an eye-rolling moment. But what I didn't expect was they went even further. And they had a section that said that they don't want ultrasound practitioners, I don't know how you would phrase it, to say living or alive in the first trimester. And they said in the document, they didn't say because technically it's not alive. They didn't try to make an argument that those words were incorrect or unclear to patients. They said that we should avoid them because people outside of medicine might appropriate those terms for political ends we don't like. In other words, if you acknowledge that the embryo is alive, that might be a problem for abortion rights. And so they're transparently prioritizing the politicization of the situation over their patients' understanding in their own pregnancies and their own circumstances. And speaking as someone who has gone to the prenatal appointment after already experiencing a loss, nervous and wondering if this time it's different, to prioritize you not wanting to say that the embryo is alive for political reasons over me needing to know if my baby is okay is, it's insane. And I feel like ACOG is doing something similar here. So one of the things I wanted to specifically hone in on is one of the phrases ACOG objects to is dismemberment ban. They say that it is, prejudicial, and they recommend instead saying dilation and evacuation. But then if you look up to date, if you look up the medical descriptions of dilation and evacuation, it talks about how this procedure often includes disarticulation, which I think is actually a very generous way of describing dismemberment. And I bring it up because, again, even if you have a patient who is seeking abortion and they want to know what's going to happen in their circumstance, how do we balance giving them information in an objective, low volatility way and making sure they're clear on what's going on? Can you talk a little bit about the difference, for example, I'm going to be very specific here, the difference between, say you're inducing labor at 15 weeks because of previable rupture of membranes, on the one hand, versus if someone induced labor at 15 weeks when there is no medical problem and the procedure is the same, how would you describe those two situations?
Yeah, absolutely. So I think this is a really important point to make, because many of the technical procedures that we use for treating pregnancy complications or miscarriage might be the same technical procedure that are used for elective induced abortions.
Right.
And so it's important to point that out. It's important to point out that no law in the country prevents an actual procedure in and of itself. They prevent that procedure with the intent of ending the life of a preborn child if that state outlaws abortion. So intent is really 100% the difference here. So in the first situation that you described, where a woman's water breaks before a baby is viable outside of her, that does pose a threat to the life of the mother because of the threat of the threat of infection hemorrhage and a small but real risk of sepsis, especially if infection is left untreated. And so one of the options for management of that would be immediately intervening to separate mom and baby. So your goal in that is your intent is to prevent that risk to the mother's life. You don't have to do that in a way that guarantees or intends the death of that child, and that's very important. So there might be some people that would intervene in that situation, and they would do something that would ensure or intend the death of that preborn child. Most practicing OBs that I know will actually induce labor in that situation after discussion with the patient. There are some who would do a D&E procedure. But many OBs will induce labor because, as you said, many families in this situation actually desire to have an intact child that they can hold and they can grieve. I think it's also important to point out that we don't always have to intervene. Of course, after talking with mom and that shared decision making, you know, some women will elect for expectant management, which ACOG says is a perfectly reasonable option for management if there's no signs of infection.
But when we talk about maternal mortality, there are levels of maternal mortality, levels that you can look at. What most people look at is the maternal mortality deaths within 42 days of the pregnancy ending, whether that pregnancy ends in a miscarriage, an abortion, or a live birth. But you can look broader into a bigger category, which is pregnancy-related mortality, and that's deaths within 1 year that are directly related to the pregnancy. And we can look even further at pregnancy-associated mortality. So that's deaths during pregnancy and up to 1 year postpartum, but from things that are not directly related to the pregnancy, but still are actually caused by or aggravated by the pregnancy outcome. So how many mothers die each year? Well, there was a very important journal article, Hogan et al. In 2010 in Lancet, that showed that there were about 300,000, little over 300,000 maternal mortalities worldwide. That's the immediate pregnancy-associated mortality. But in the absence of HIV, there was about 281,000. But compare that number to the 500,000 claimed by UNFPA at that time in 2010. So you can see that the numbers are exaggerated. The Hogan study was a very well done study, and we're getting a discrepancy between what the abortion advocates claim and what is in reality. Hogan also found that more than 50% of maternal deaths occurred within 6 countries: India, Nigeria, Pakistan, Afghanistan, Ethiopia, and the Democratic Republic of the Congo. Hemorrhage and hypertensive disorders were the major contributors to this immediate maternal death in developing countries. So if your goal is to make motherhood safer, then your enemies are preeclampsia, postpartum hemorrhage, infection, HIV, and physical obstacles to access care during delivery. Then it's easy. You improve maternal health by improving prenatal care, safe delivery facilities which are adequately staffed and equipped, transportation so that women can access these facilities, and female literacy, which actually turns out to be a very important factor, because if you are not literate, you can't understand written instructions. In 2007 in London, I was privileged to participate in the first international pro-abortion conference called Women Deliver. And I went there with 6 other pro-life female leaders to this conference to find out what the pro-abortion side internationally was planning and what they were thinking. And they were very confident that no one who was pro-life was at the conference, so they were very free with their discussions. This happened in September of 2007, and it marked a triumph of the UNFPA feminist part of the partnership over the safe motherhood part of the partnership. And the conclusion of this conference was that we're going to establish abortion first worldwide. At one of the sessions, the planning committee had a talk on what are the obstacles to implementing worldwide abortion, elective abortion. The number one obstacle was the presence of Protestant missionaries in the healthcare system in Africa and the presence of the Roman Catholic Church in the healthcare system in Latin America. But they had methods and ways that they were going to take care of this problem. Obstacle number two was the idea of healthcare workers' rights of conscience, which allowed health professionals to refuse to do abortions. They also had plans to take care of this problem as well by eliminating physicians of conscience from the healthcare systems globally. The number three obstacle was the use of ultrasound in obstetrics, which unfortunately turned the mind of the woman to the possible humanity of her fetus. And number four, which was quite stunning to me, was that the people themselves do not want abortion worldwide, but we will work through the courts to give it to them anyway, imposed legally, top down. So now we get into this term safe and unsafe. What does that mean when you associate that with abortion? Well, the term safe usually implies risk-free. There's no risks. This is a safe procedure. But abortions are lethal to the unborn child, and they carry greater short and long-term risks for the mother than giving birth. But the WHO, the World Health Organization, mixes legal and medical definitions to imply that, to say that legal is the same as safe, and to promote elective abortion legalization worldwide. Now that's a big claim on my part. Can I prove that? If you look at the Lancet edition, the Lancet in October of 2007, it was all covering it was in preparation for the Women Deliver Conference. And one of those articles within Lancet at that time was talking about defining safe and unsafe abortion. And it was a very remarkable article if you read it carefully. So what they said was, for estimation purposes, safe abortions were defined as those that meet legal, not medical, legal requirements in countries in which abortion is legally permitted under a broad range of criteria. For a physician, that is a very strange definition of safe, but it's a legal definition, not a medical definition. And that's the important point to understand. Unsafe abortion was abortion by the unskilled, not meeting minimal medical standards, but also note, these include abortions in countries with restrictive abortion laws, so where abortion is illegal. So regardless of the medical safety, an abortion performed in a country where abortion is illegal is by WHO definition an unsafe abortion. So let's go on to unpack this, because this is a very interesting way of thinking about safety and non-safety that's foreign to us as physicians. When performed within the legal framework, the safety of the procedure will depend on the requirements of the law, as well as the resources and medical skills available. In some countries, lack of resources and skills may mean that even abortions that meet the legal and medical requirements of a country would not necessarily be considered sufficiently safe in high-resource settings. What in the world does this mean? It means that a procedure labeled as a safe abortion in the developing world because it meets legal requirements would not be a medically acceptable abortion in resource-rich nations. Why in the world would this kind of definition be proposed? Well, it has to do with the effect of this definition on policy. So if a country simply legalizes abortion, poof, the total number of unsafe abortions magically decreases, because most abortions now, quote, meet legal requirements, which is the WHO definition of a safe abortion. But the women still die. And now they die in greater numbers, since the total number of abortions increase with the legalization of abortion. In every country where abortion has been legalized, the total number increases. But now these women's deaths become invisible to official statistics because they are deaths from safe abortion, and safe abortion deaths are not routinely tracked. And this may be something that you can do in your country to start tracking, quote unquote, safe abortion deaths. It's a brilliant legal strategy. It is heinous medical care. Safe, we have to understand, is a legal term. and safe abortions carry real risks of harm to women.